Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Expecting parents have a lot to learn, especially first-time mothers. While Rebecca Ernesti was pregnant last year, a surprise diagnosis meant that she had even more to learn in order to keep herself and her baby healthy. Rebecca had gestational diabetes, and thankfully she was willing to engage with an expert nurse who helped her understand how to manage the condition. Today, we are learning more about what gestational diabetes is and what it means for both mother and baby. Plus, as we wrap up Nurses Week, we are meeting a nurse who helps parents navigate complex and sometimes nerve-wracking pregnancies. But first, let's get to our morning rounds. New research published in JAMA Oncology questions the timing of colonoscopies. Is 15 years the new 10? The study suggests that if you are at average risk of colon cancer and your first colonoscopy comes back clean, it might make sense to wait 15 years until your next one instead of 10. We are joined by Dr. A.J. Bansal. He is the medical director of the Gastroenterology Cancers Prevention Clinic here at the University of Kansas Cancer Center. Dr. Bansal, good morning. How are you?
Good, thank you.
Good to see you. So the findings of this study, of course, they sound nice for people who don't enjoy the average colonoscopy, right? But if someone waits that extra 5 years, does that increase the possibility of missing a cancer?
So that's a great question, Jessica, and an important topic. So let's think about how colon cancer begins. It begins from polyps in the colon, just like a mole in the skin, which can turn into melanoma. So by doing colonoscopies, we can remove those polyps. So people who have negative findings on a colonoscopy and do not have any polyps, and it was a good quality colonoscopy and a nice prep, in those cases, it does seem that probably the intervals could be stretched to longer compared to from 10 to 15, but we still have to wait for more information.
So the truth is, we know not everyone follows current screening guidelines. We wish they did. But if everyone did follow those guidelines, would there even be enough GI doctors out there to do all the colonoscopies that it would take?
So what Jessica is referring to is the drop in colonoscopy age from 50 to 45. The reason for that is a lot of new data in the past decade which has shown that the risk of colon and rectal cancers have increased over the past 10 years. And to prevent those cancers, we need to start earlier so we can find the cancer at the polyp stage. So there will be regional differences in the availability of colonoscopy. There will be other competing methods which can be used, stool-based tests and maybe now blood-based tests, which may be a solution in many places where we do not have enough gastroenterologists.
So we need to reiterate that these findings apply to people with an average risk of cancer. But what does it mean to be at a higher risk for colon cancer?
That is a very, very important question. So what we mean by average risk individuals at risk of colon cancer is that these are patients who do not have a family history of colon cancer, no multiple second degree, first degree, third degree relatives with colon cancer. And that's one of the main ways you'll understand if they are average risk or high risk. And also some patients may have family history of syndromes which run in the family like Lynch or polyposis. Those would also be considered high risk.
Dr. Bansal, before we let you go, any other final comments?
So my feeling is that the best test for preventing colorectal cancer is the test which gets done. Mm-hmm. So be it a colonoscopy, be it a stool-based test, get it done because colon cancer is truly preventable.
Dr. Bansal, thank you so much. Good to see you on this Friday.
Thank you.
Well, pregnancy changes your body. Some changes are expected and some changes can be quite a surprise. And one of those surprise changes in pregnancy is this gestational diabetes, or GDM. Today we are learning more from our guest, and we've got Penny Peters. She is a nurse in maternal fetal medicine clinic here at the University of Kansas Health System. She is also a certified diabetes care and education specialist. Good to see you.
Yeah, thank you for having me.
Yeah, and Rebecca Ernesti, she's a mom who says that she's learned quite a bit from Penny, right? Mm-hmm. Because you had been diagnosed with gestational diabetes. Thank you both for being here to talk about this. And Rebecca, first of all, let's talk about your baby. We need name, how's she doing, and tell us all about her.
Yeah, she's Piper. She's 6 months old. She's perfect.
Perfect, yeah, basically.
So cute.
Obviously. Is this your first baby?
Yes.
Well, good. How's it going?
Good.
I know, right? Yeah. It's just like, who knew you knew how to be a mom?
I guess so.
It's just like you go, that instinct just kicks right in. Mm-hmm. And how are you doing?
Good.
Good? Good? Mm-hmm. Good. Rested?
Yeah. She's a good sleeper. She's a good sleeper.
Russ, I asked if you're rested, and I don't know if I totally believe you. But so take us back. So you go to your your doctor, and away from the health system. But when you came to the maternal fetal medicine clinic. How did you find it, and what made you decide to come here?
I had already been I have a few doctors here, and so I just sort of researched, and I was like, I'd rather go to KU than the one that they were recommending.
Well,
so.
we're glad you did. So you were diagnosed with gestational diabetes. How did you learn you had it?
At 22-ish weeks, the glucose test was I think a 1-hour test. And I failed that, and then I had to take a 3-hour test after that.
So I remember taking that. I didn't know about gestational diabetes. They just said when you're pregnant, they're like, you go in, you drink this disgusting, can I say that? It's just this gross.
It's gross.
It's like this, it's like Gatorade flavored glue. Delicious, right? So you take it, but yeah, I had never heard of that either. So I wasn't expecting it to come back as anything, but you get this diagnosis. Had you ever heard of this before or knew what this was?
I knew what it was, but didn't really take it seriously or anything.
Okay, so you get the diagnosis. What did you think? Were you concerned? Were you just like, we got to get to the right spot?
Yeah, I was pretty freaked out about it, sort of. Yeah.
Yeah, no, I would imagine. Penny, help us understand exactly what gestational diabetes was. Like her, I didn't know what it was. I was just kind of going through the motions. How does it differ from what we think of as type 1 or type 2 diabetes?
The main difference is it happens in pregnancy. All these all these hormones when you're pregnant come out, and some of them make you insulin resistant. So the farther along you get, the more we see this insulin resistance. So it's not type 1, it's not type 2, it's truly caused by the pregnancy.
Okay, that's interesting to know. So how common is it? Are there certain groups of women who are more at risk of getting it than others?
Yeah, the CDC says between 2 and 10%. I feel like we're seeing it rise. And people with a family history of diabetes are more prone to getting it, sedentary lifestyle, and then things like other comorbid conditions. So if you have PCOS or anything like that, you baseline insulin resistance, prediabetes, you could get gestational diabetes just a little bit easier than someone else.
So if gestational diabetes is uncontrolled, so what are the risks to the mom, and then what would be the risk to the baby?
They kind of go hand in hand. So the risk to mom and baby is baby's growing very large. And as you can imagine, it's not healthy for baby to come out very large, and it's also difficult for delivery, which can cause trauma for mom and for baby. Also, if babies are exposed to that high blood sugar in the womb, when they are delivered, they have a hard time adjusting and regulating their own blood sugar. So yeah, if it's uncontrolled, it can be pretty severe.
So this would require a lot of patient education, if you will. That's where you come in.
Yep.
So how much education do you have to give a mother to know how to navigate and manage this?
Quite a bit. The initial introductory class we have people come to is 2 hours, and it's kind of lecture style. We just throw a bunch of information at you, and then there's follow-up throughout your pregnancy as we start medication or we make changes. So it's kind of just a learning process from diagnosis to delivery.
Okay, so tell me more about this education in this class, and what are you learning about are you learning what to do on a day-to-day basis, how to eat, what?
Yeah, kind of the whole gambit. What is gestational diabetes? What caused it? And then how to manage it. So we have a dietitian from the Cray Diabetes Center that is amazing. They come and they do about an hour-long, what is a carb? How do you count carbs? What do you need to eat? Sample menus. And then I come in and I kind of do more of the, okay, here's what's going on, and here's how we're gonna check your blood sugars and follow up with your doctor. So it's just a big, broad class for 2 hours when you get diagnosed.
What'd you take away from the class?
Well, I actually skipped the class because I already knew about those things.
Okay, so how was it to have to make changes in the middle of a pregnancy? I mean, you've got so much going on, and a lot of people just kind of want to be able to do their own thing, eat what they want, kind of curb the cravings, things like that. So what kind of changes were you making for you specifically?
Well, my aversion during pregnancy was meat and protein, and my cravings were carbs. So I had to reverse that.
Oh, you did. So you really had to up the protein. What kind of things were you eating? Just regular, just meats, and anything else that you incorporated into your diet?
Yeah.
Anything else? So I guess this just means sweets are out? Is it fair to
Sort of,
say?
yeah.
I mean, is that just okay? So there, you can sneak them in. Okay, because I was like, come on.
Really small, a little bit.
It's like she's throwing a baby in there.
I
Let-
know,
give the
that's all
girl-
I wanted.
I know, give the girl a break. So, of course, we know that diet and exercise helps with overall health. Everyone knows that. But how does that diet and exercise really specifically help with gestational diabetes? We talked about diet, but specifically exercise.
So insulin resistance is the whole crux of this issue. When you exercise, it opens up your cells and lets that insulin do its job and take the glucose into the cells for energy, so it's not just floating around and giving you high blood sugar. So exercise is vital. We say 30 minutes a day of just something simple like walking. I mean, in your third trimester, you're not really wanting to do a bunch of exercise, but a 10, 15-minute walk after you eat, you can see an improvement in those numbers.
What were you doing? Just doing some light walking? Did that help?
Yep.
Did you feel the
Walked around the
difference?
block.
Walked around the block. That's good.
And it
That's
definitely did help.
good. And she mentioned carbs kind of being her thing, as
Yeah.
it is a lot of folks. What do carbohydrates do during gestational diabetes, and how can that affect it?
They break down into sugar. You need them. You need glucose in pregnancy. We're just trying to mitigate the rise. So like Rebecca mentioned, doing protein with your carbohydrate. Like we say, never eat a naked carb. You always want to have some protein or some fat with that carbohydrate. So it breaks down a little slower, and we're trying to avoid those big spikes in blood sugar.
So are there GDM symptoms that pregnant moms should be aware of?
No, everyone gets screened with that lovely glucose drink we've been talking about.
Let's talk about that again.
Yeah.
That test, and it's standard. Is this what you're saying?
Yes.
If you're pregnant,
Yes.
your provider will be sending you for one of these tests.
Yeah, because there are no symptoms. And like we said, if it's uncontrolled, it could be serious. So every single pregnancy, you get screened.
And you said 22 weeks you did that. Is that correct? So what's the earliest you can detect it? Is that about right?
Yeah, standard screening, 24, 26, 28 weeks. But we do see a lot of providers doing the 1 hour, because as Rebecca mentioned, you do a 1 and then you do a 3. So sometimes we start that 1 hour a little earlier, so you get time to get back in and get the gumption to do your 3 hour and see how it goes.
I do remember that. I really do remember that. Okay, so if you have any questions you want to ask, if you want to ask Penny or Rebecca one, send those in. You can use the chat on YouTube or Facebook. We are on the X platform, or you can email the Medical News Network. The information is there on your screen. So does gestational diabetes go away after a baby's born?
Ideally, you deliver the baby, deliver that placenta, and along with it, those hormones go back to normal. But you're always at a higher risk for getting type 2 diabetes. So they do screen you postpartum between 6 and 12 weeks with another glucose tolerance test to make sure that blood sugars are back to normal.
So how do you talk to a mom, just from a mental health perspective? Are they ever concerned that it's something they've done, or felt like maybe it was their fault?
Yes, that is the most common question I get.
They'll say, what did I do?
What did I do?
wrong?
Did I eat too many sweets? Did I, not move enough?
And what's your answer?
No, absolutely not. This is
Good.
how your body is responding to pregnancy. I've had gestational diabetes 3 times, and I know all the right things to do, but it still happens because the hormones are the same in these pregnancies, and it just affects people differently.
So you said you talk about in the class what causes it. So
Yes.
does it cause it? Are there different things that cause it, or is it just the pregnancy itself?
It's the pregnancy.
Just the pregnancy.
Just the hormonal changes.
So random. It could just be a random person
Yeah,
who.
super healthy, day-to-day life, eats perfect, exercises, you can still get gestational diabetes.
Okay, I'm
It's
glad
not
you
your
said that.
fault.
I don't think, because when we think of diabetes, people immediately go to, you're not eating right.
Yeah.
You're not, so okay, good to know that. So Rebecca, talk about your mental health during pregnancy. Any challenges? How did you keep things going strong?
Yeah, it was pretty challenging. Like leading up to it, I think I was fine. I was like getting used to the pregnancy and everything, and then I got the diagnosis, and I kind of took a hit there for a while. But after I learned more about it and figured it out, I started getting back to normal.
Kind of the old knowledge is power thing. How was postpartum for you?
I think it was good.
Good.
Yeah,
Good. Yeah.
as far as I know, anyway.
You got a nice healthy baby.
No,
so
exactly.
that's something to be up about. How about your partner?
He's good.
Good, doing good,
Yeah.
handling everything good.
He loves fatherhood.
He loves fatherhood. Is that what
Yes.
you said? He's pretty darn good at it. What's his
Yes.
name?
Brian,
Brian. Okay, so Brian and Piper. Fantastic. And she's how old again?
6 months.
6 months. Good. Love it. All right, let's get to some community questions this morning, shall we? Okay, so if someone who already had diabetes gets pregnant, are they just considered to be at higher risk of gestational diabetes? And what I'm learning from you is no, or are you at higher risk because you already had it?
If you have diabetes like type 1 or type 2, you wouldn't get a new diagnosis of gestational. We would just manage the type 1 or type 2 diabetes throughout the pregnancy. So you wouldn't have to do that screening. We already know there's some impaired blood sugar going on, so we would just hop on it right away. From the time that you find out you're pregnant, we would start managing that.
So does everyone with GDM need insulin injections?
No, it is the gold standard of treatment in pregnancy. So if someone gets put on insulin, a lot of the times it's another, oh, what did I do wrong? Like I'll try harder, and it's like, no, this is what we do to treat. But I'd say about 40% can do diet and exercise. Well, 40 to 60% could do diet and exercise. But we do have a high amount of people who need just that little extra help, that extra insulin.
Did you have insulin?
Mm-hmm. Yes, I did.
What was it like? Did it feel any different? Did it affect you in any way?
It didn't actually, and I kind of like wanted it.
Yeah.
Because I knew it would help, and I knew
You were open to it.
Yeah.
Open to the treatment.
It was easier than just trying to manage it on my own.
Exactly. So question is, had you ever met anyone else with gestational diabetes? I mean, you said you knew a little bit about it, but had you ever
Not in person,
talked to
no.
anybody? Okay. When should a mom know that they should be seen at your clinic versus just sticking with their regular doctor? When do they need to kind of up it?
It's kind of dependent on your OBGYN. So some of OBGYNs, they really like to keep their moms with gestational diabetes and do the management. Usually if insulin's involved, they'll send to maternal fetal medicine. And then some providers just want to get that initial consult, okay, you have gestational diabetes, you're going to maternal fetal medicine, regardless of medication need, just to have that knowledge and go through the education and meet the providers.
Question. You had this 3 times. Is that why you got into this?
Yes.
Okay. So you have this major perspective.
Yeah.
Tell us more about your pregnancies. What were they like? Did they seem the same with all 3, or did you have different experiences?
It kind of progressed. So the first one, I was totally shocked, like Rebecca. I was like, whoa, what's going on? The second one, I knew I was at a higher risk because if you've had it once, same hormones the second time around. So started testing earlier. Third time, it was kind of a guarantee. I knew right off the bat. I was like, all right, let's start doing the screenings, checking the blood sugars. And by that time, I worked in maternal fetal medicine. So it was just, my bread and butter by that point. I was like, all right, let's manage it. Let's do it.
Well, and how relieving though if somebody gets in front of you and you're like, hey, I've been there, done that 3 times.
Yeah.
And then they probably ask, well, and your kids are healthy, I take it?
Yes, my kids are healthy. I don't have diabetes outside of pregnancy, so it is kind of good to be able to share that with patients and let them know you're not alone. And besides the medical side of it, I can kind of provide a little extra support if you need it emotionally, just because this is a huge change.
Oh, big time. So, Rebecca, did you have to check your blood sugar? And how often did you have to take insulin?
I had to check my blood sugar 3 times a day, I think. 6 months ago, it was a long time.
Yeah, lots have happened.
But like after your meal, an hour after your meal, and then I took insulin in the morning and at night.
So once she's done with the pregnancy, does she still need to continue to follow some of the guidelines that she's been taught? Some of the diet needs, exercise needs, or does just one have? Always a good idea, but does one have anything to do with the other, especially as she goes into her next pregnancy, possibly?
Yeah. So postpartum, I tell everyone, I don't want you carb counting and obsessing postpartum. You have a new baby. It's a whole big life change in itself. But kind of keep in the back of your mind that you're at a higher risk for gestational again in the next pregnancy or getting type 2 in the future. So I just say, be conscious of it. And then we do another screening, like I said, 6 to 12 weeks postpartum. And they'll check your blood sugar right after you deliver, like the next morning fasting. So that way, if for some reason your blood sugars are still high, we'll get you taken care of. But usually that fasting check is normal. You just kind of go about your life and then test again to make sure that everything has gone back to normal postpartum.
Question, what's the likelihood of needing a C-section when you have gestational diabetes? Does that come into play at all?
That's a really, really common question.
Why?
And,
I didn't think of it that way. Why is that?
Because you think I'm going to have this giant baby. If my blood sugars are uncontrolled, I'm not going to be able to have a vaginal birth. I'm just going to have a C-section, and that is just not true. We don't see that. The indication for having a primary C-section just because you have gestational diabetes, I mean, it's super rare. I never see that in the clinic. If you want a vaginal delivery, that's what we're here. We want to accomplish what you want to accomplish. So a lot of people do kind of mourn this loss of, I'm going to have a C-section now. I didn't think I would. And it's like, no, back up. We're getting way ahead of ourselves. We're going to just do what we can to support you.
Yeah, you might need a C-section, but it may have nothing
to do with your diabetes,
with
most
this.
likely, yeah. Mm-hmm.
Does Rebecca remember what her first question was regarding this diagnosis? Like, what was your big question that popped into your head?
Oh man.
I mean, I'm sure there were 50.
There
but
was
can you- but what do you think was that one that you're like, I need some peace of mind about this one thing?
It was probably if I would have to go early.
Early.
Yeah.
Yep.
Talk to us about that, Penny. Is there a possibility of having to take a baby early for that?
Yes. So the old guidelines a couple years ago, 39 weeks, we would say we're going to do an induction. Now there's some more research and some more evidence saying if you are not on medication, you can go to your due date of 40 weeks, but we don't recommend going past it. And of course, it's always shared decision making between you and your doctor. Like, no one's going to come in and be like, all right, you have to have this baby today.
Right.
So I feel like that's something people think too, oh, they're just going to say, I have to do it now. And it's like, it's a conversation. It's a process, and there's options. So,
Rebecca, you had mentioned that you did not take the class. So where were you able to learn more about gestational diabetes?
My OB had given us some preliminary stuff, and then of course I Googled it. And
You went down the rabbit hole.
I did.
That's all right.
Definitely
There's some
did
good
that.
stuff on there, but yeah. But what does it mean, though, Penny, to be a certified diabetes education specialist? What does that mean?
it means that I have a medical background. So if you're a registered nurse, registered dietitian, you can get this special certification. It just means you have extra training in these areas. So like anything, you have to pass a test, you have to get certified, you have to have clinical hours. So it was a lot of work to get the certification, but people all over the health system do pursue that.
Is this diagnosis becoming more common for any reason?
I feel like it is, anecdotally, seeing it more commonly, the same way that type 2 is on the rise, a lot of it is just a lot of healthy women are getting screened earlier, so we're catching it. You get your A1C checked as soon as you find out you're pregnant. So I think there are more diagnoses just because of more screening.
Interest. I was going to say, it always comes down to screening.
Yep.
Yeah, it's number one. What do you want people to take away from this conversation? What's the most important thing to know today?
I think the most important thing is it's not your fault that this happened if you have it. We're here to support you. Like, you're not alone. This is a serious condition, yes, but it is manageable. You have a whole team in maternal fetal medicine here, from diagnosis to delivery, that is trying their best to help you through every aspect. So, yes, it is a bummer that you'll have to count your carbs, but also, we got this, you got this, everyone will have a lot of support.
So, Rebecca, thanks for being here and sharing your story. Glad your baby is healthy and you all are doing well. What's the big takeaway from your experience?
Definitely take it seriously, but don't overly stress about it. It'll be okay.
Thank you.
She's happy and she's healthy.
That's all that matters. Thank you both for being with us today. Appreciate you. Thanks to all of our viewers as well. We'll see you back here on Monday. Coming up Monday on the Morning Medical Update, food allergies can hurt your stomach and your wallet. When Emily Brown went to a food pantry, she saw there weren't many options for her 2 little girls. I'm Jessica Lovell on the next Morning Medical Update, raising awareness while turning adversity into opportunity. How this mom's experience is helping communities of color living with food allergies. Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now, everywhere podcasts are available.